Hello students, so we will start our neurological emergencies, and one of the common reason to visit the emergency department is altered consciousness, right? Or in normal language we call it coma. So what is this coma? Coma is one of the common reason to visit emergency department, and it is one of the most difficult condition to manage because of its complex presentation and multiple etiologies. I mean, there is no such conditions which cannot lead to coma. So it has such a multiple etiologies. So we need to have a very systematic approach in coma patients. Rather than focusing on approach, we should more focus to prevent damages which can happen due to coma in emergency department. So basically in emergency department, we have to stabilize a coma patient, and that is what we need to discuss, stabilizing a coma patient. Okay, so now what is this coma or altered consciousness? Now a person remains conscious depends upon few intact anatomical and physiological process, basically two interdependent anatomical and physiological process, and anywhere problem, right, would result in coma. So what are the parts on which the arousal and awareness of a patient is dependent on? So patient can be aroused, patient is aware of his surrounding, depends upon two anatomical and physiological interdependent pathway. Now arousal and its underlying neural substrate depends upon the ascending reticular activating system, ARAS, ascending reticular activating system, and diencephalon, right? So if patient A can be aroused or not, it depends upon ARAS, ascending reticular activating system, ARAS, and your diencephalon. The phenomena of consciousness requires two intact and interdependent physiological and anatomical components. So if a person can be aroused and is aware, dependent upon few interdependent systems, and problem in any of it will result in coma. So arousal, person can be aroused. It depends upon ascending reticular activating system and diencephalon. And awareness, right? Awareness of surrounding, awareness of body, awareness of everything depends upon intact cerebral cortex. So any problem in cerebral cortex or any problem in ascending reticular activating system or diencephalon can result in coma, right? So this coma, the arousal, and drugs can affect these systems, your trauma can affect these systems, right? So there are multiple etiologies which can affect the system, which can result in coma. Okay, what is the definition of coma? Now coma is characterized by an uninterrupted loss of capacity for arousal. Now what happens that eyes may remain closed and it may also remain open. So it may remain closed, and sleep-wake cycle of the person disappears, and even with vigorous stimulation, even if we give the best stimulation to the patient, only a reflex response is elicited. Patient only show a reflex response rather than a conscious response. Okay, so it's uninterrupted, not patient becomes conscious and then goes again into unconsciousness. This is not coma, this is more of malingering. But coma is uninterrupted loss of consciousness, right, in which eye may remain closed and sleep-wake cycle of the person is disturbed, and even with maximum stimulus, only reflex response can be elicited. So this is what is definition of coma. Now it is acute and potentially life-threatening, right? So evaluation of coma patient demands a very systematic approach. If we do not have a systematic approach in evaluating a coma patient, right, then it is very difficult to come on the etiology or the cause which is causing coma, and it would be very difficult to prevent the damages caused by this altered level of consciousness. So we need to have a systematic approach for all our diagnostic and therapeutic endeavors. Okay, So how do I approach a coma patient? We need to take some urgent steps, right, to prevent or minimize, maybe if we cannot prevent, just to minimize the permanent brain damage from reversible causes. So if coma is due to some reversible cause, it can be due to irreversible causes also. But if it is due to reversible cause and things can be reversed by us, by an urgent approach, we can prevent and minimize the brain damage in these patients. Now, before going into those steps, before telling you the approach of coma, let us very fast see the vast etiology resulting in, which can result in coma. Now, structural brain lesion. I told you that consciousness, person is conscious, it depends upon arousal and awareness, and all the centers which manage arousal and awareness is in your brain: cerebral cortex, diencephalon, ascending reticular system, etc., etc. So any structural brain lesion, right, can cause coma, like subarachnoid hemorrhage, intracranial hemorrhage, ischemic infarction, global cerebral hypoperfusion, cerebral venous sinus thrombosis, traumatic brain injury, hydrocephalus, basilar artery occlusion, central pontine melanosis, large hemisphere masses, any mass, right, pituitary epilepsy, then cerebral abscess, anything, any lesion in the brain, any space occupying lesion, or hemorrhage or mass, hemorrhage, hematoma, trauma, anything, any problem in brain can lead to coma. So virtually every pathology of brain can lead to coma. Then apart from brain pathology, there are so many metabolic and systemic disorders which can lead to coma. First and most important, hypoxia. Hypoxia or anoxia can lead to irreversible brain damage, can take the patient into coma. Hypercapnia. If asthmatic patient retains CO2 narcosis, hypercapnia can lead to coma. Hypotension, because of inadequate perfusion, again it will have effect on the arousal and awareness of the patient, can lead to coma. Hypoglycemia can lead to coma. Hyperglycemia can lead to coma. Diabetic ketoacidosis, hypernatremia, then hypercalcemia, your hyperthermia, Wernicke's encephalopathy, hepatic failure, liver failure, or uremia, right? Any of these metabolic and systemic disorder due to electrolyte imbalance, due to toxin produced in the body, can affect the awareness and arousal of the person and can lead to the coma. Okay, so when we are trying to diagnose, trying to look in the etiology, we have to keep all these, trying to find out the etiology, we have to keep all these in differential diagnosis, right? Then any infection and inflammation of the brain can lead to coma, right? I told you, any brain pathology, a space occupying lesion, structural brain lesion which I discussed. Now even infection or inflammation of the brain can lead to coma. So meningitis, meningitis, right? Your syphilis, sepsis, malaria, right? Systemic infection, not necessarily brain infection, systemic infection can also lead to coma. Sepsis can lead to septic encephalitis. So infection, inflammatory lesion of the body can also take the patient towards coma. Drug and toxin. Multiple drug and toxin can produce coma, like alcohol, opioids, your sedative agents, like patient in ICU, I have given a huge amount of sedation, any sedative agent can also produce a temporary coma in the patient. Carbon monoxide poisoning, arsenic poisoning, right? They can also lead to coma. Apart from that, we have psychogenic coma, which we need to distinguish from the, let's say, from the real causes of coma. Then heat stroke can also lead to coma, right? Heat stroke leading to coma mostly because of hypovolemia, hypoperfusion, etc., etc. Okay, so you can see there are so many differential diagnoses of coma. So many causes which can lead to the altered consciousness. So we need to have a very systematic approach if we want to diagnose coma. But before diagnosing, the most important thing is to know the gravity of the situation. That patient is how much deep in coma is my patient? What is the prognosis of this patient of mine in coma? So prognosis of a patient in coma can be measured by something called Glasgow Coma Scale. Now, what is this Glasgow Coma Scale? Glasgow Coma Scale is a widely used as standard method for describing neurological function in a quick and a concise way. So very quickly and concisely we can measure the neurological we can do a neurological assessment of a patient by GCS, popularly known as GCS or Glasgow Coma Scale. Now this Glasgow Coma Scale is based on 3 responses: eye response, vocal response and motor response. Eye response seen in the patient, vocal response seen in the patient and motor response. So we call it EVM, right? We mark it as EVM. And minimum value for each is 111 and maximum value differs. But basically the minimum GCS of any person can be 3 and maximum can be 15. So it varies from 3 to 15. We'll see how the GCS is calculated. So this tells us about the gravity of the situation, how deep patient is in coma, how the neurology, and it will also guide us in our therapeutic measures which we have to take the patient in coma. What measures we have to take in this patient, it can also be guided by GCS, Glasgow Coma Scale. So by Glasgow Coma Scales we are eliciting how deep the coma of the patient is, what are the management we have to do in these patients, and what is the prognosis of this patient. Lot of things it is telling us. Okay, so how do we measure GCS of a patient? How do we measure GCS of a patient? I told you it is based on 3 response: eye response, motor response and vocal response. So eye opening, let us talk about eye response. Eye opening, if a patient has a spontaneous eye open, I told you in coma when I was discussing the definition of coma, that patient's eyes may remain closed or it may remain open also. So if there is a spontaneous eye opening, we give it a value of 4, score of 4. If I call the name of the patient, yes, please open your eyes, and patient opens. Vocal response to eye opening. If patient responds to speech, then 3. And if I give a pain stimulus, and then patient opens his eyes, then we call it, we give the score 2. And when there is no eye opening, not on speech, not on pain, we cannot elicit any eye opening, then we give it value 1. So spontaneous 4, vocal 3, to pain 2, and no eye opening 1. Okay, so this is how we elicit the eye response. Then comes vocal response, verbal response. Patient is oriented, talking sense, then we give it the score 5, right? Patient is talking but is a bit confused, saying few normal things and few things of past. He's mixing, he's not understanding where he is. He is in a situation where he doesn't have a clear-cut understanding of the surrounding, etc. He's confused. Then we give the score 4, right? Then patient is talking inappropriate. Like if I ask my patient, yes, who are you, right? Then I get a nice reply, he tells his name and he's from where, then he's oriented. Then patient know who he is, but cannot tell where he is, what has happened to him. He's confused, but he know who he is. He is confused. Then I give the score 4. Then inappropriate talking. Patient is talking nonsense. He's not saying sense. He's not giving answer to my question. He's just an inappropriate talking. Then we give 3. Then patient is trying to say something but cannot comprehend it, cannot make a sentence out of it. We are seeing that patient is trying to give us some information, but he cannot form a sentence for that information. He is incomprehensible. Then we call it 2. And no verbal response, then of course 1. So in motor response, right, in motor response, if I ask the patient to move his limb, he obeys the command, we give him 6. If I give a pain stimulus and he localizes the pain stimulus, then we give 5. And if I give the pain stimulus, right, and just patient shows a withdrawal response, right, then we give 4. If patient shows a flexion response to the pain, then we give 3. Extension response to the pain, then we give 2. And no response to the pain, then we give 1. Sometimes it is difficult to distinguish between the withdrawal response and extension response, right? So just remember that extension response, patient will have just a minimal extension, a decerebrate kind of feature in all his forelimb, right? Decerebrate, he's decerebrating. Withdrawal response, patient cannot localize the pain, but just he's moving his limb vigorously to the pain. He is trying to localize the pain, but he is unable to elicit exactly what place the pain stimulus is being given. So he's just showing a withdrawal response, trying to move his body and trying to wake away the pain stimulus which we are giving to him. And withdrawal response is very different from the extension to the pain response. Extension to the pain response is more a decerebrate kind of feature. Okay, so we calculate the GCS. Now I had a patient whose GCS I calculated was 6. Now when the patient GCS is less than 9, now previously it was like less than 7, but nowadays the safety margin has increased. Now if the GCS of the patient is less than 9, then definitely we need to secure the airway of the patient. Patient may breathe. Number of times in coma, patient is in coma. Patient respiratory center is fine, patient can breathe, but patient cannot protect his airway from aspiration. So in coma patient, normally if he has a GCS less than 9, we intubate the patient to protect the airway from aspiration. Okay, so this GCS has a lot of value. So we do a quick GCS assessment of the patient. Now how do I approach a coma patient? How do I approach a coma patient, right, in emergency department? A, B, C. Like any patient coming to emergency department, right? Coma patient also we have to assess on the basis of A, B, C. Airway, A for airway. Guys, number of time patient airway may be compromised, it may be obstructed, patient cannot protect his airway, right, from tongue, etc. So obstruction of the airway is happening. The number of time head tilt chin lift, or jaw thrust mechanism opens the airway. Okay, so we see by opening the airway, the patient, let's say airway, by doing these maneuvers, whenever airway of the patient is compromised, we start with the maneuvers like head tilt chin lift or jaw thrust, right? If patient airway does not open with it, or if it opens and we want a more permanent thing, then we can put a airway in the patient. We can put a oral or a nasal airway in it, right? So I will put a oral airway or a nasal airway in the patient and try to lift the tongue above the airway and prevent the tongue from compromising the air, obstructing the airway. If patient's airway does not open with this also, right, after putting the nasopharyngeal or oropharyngeal airway, then we may need to put an advanced airway. We may need to put a supraglottic airway device, or we may need to put a endotracheal tube in this patient. So depending upon which maneuver of mine is opening the airway, we go in a sequence. We try with the maneuvers like head tilt chin lift or jaw thrust. Trauma patient, we never do head tilt chin lift, we only do jaw thrust because we don't want the cervical spine to move. How do we do head tilt chin lift? I have discussed it in my video on respiratory emergencies, right? Okay. If these maneuvers are not opening the airway, then what do? I put nasopharyngeal or oropharyngeal airway. If the airway is also not opening the airway, then what do? I go for advanced airway like supraglottic airway device or our endotracheal tube. So I have opened the airway. But breathing of the patient is not adequate, right? Now, even if I have opened the airway and patient is breathing, then also in coma patient, we need to keep the saturation little higher. So we always attach 100% oxygen. So if patient has a adequate breathing effort, right, but needs a supplemental oxygen because we want to keep oxygenation 100%, right, so I can attach a oxygen. And if patient breathing is not good, then we can go for bag and mask ventilation and give 100% oxygen. Okay. Then I go, after systematic approach of A and B, I go to C, circulation. We assess the circulation by assessing the pulse, assessing the adequacy of the circulation by capillary refill, visibility, feeling the temperature of the patient, right, seeing the blood pressure of the patient, right. So I assess the circulation of the patient. Okay. In coma, right, we need to keep mean arterial pressure above 100 mm of Hg. Both hyper and hypotension can be deleterious, but aggressive control of blood pressure is not required because it will affect the perfusion of brain. So mean requires, right, to be kept above 100 mm of Hg. Mean arterial pressure need not decrease from 100 mm of Hg. If mean blood pressure of the patient is above 100 mm of Hg, right, we need not decrease it. We need not put the patient and try to attain a normotensive value. If patient is in hypertension, the mean arterial pressure is above 160 mm of Hg, then only we decrease the blood pressure, right? And whenever I choose a hypotensive agent, we have to be very careful in coma patient because most of the hypotensive agent also increase intracranial pressure. So we always have to choose the hypotensive agent that do not increase intracranial pressure by their vasodilating effect, right? So remember, your nitroprusside, nitroglycerin, they are increasing intracranial pressure because they have a vasodilating effect and they are increasing intracranial pressure also. But your esmolol, right, esmolol is a hypotensive agent which does not increase intracranial pressure. We can use it in these patients. Okay. We need to keep the blood pressure enough above 100 mm of Hg so that we get a good urine output, right? Urine output should be 0.5 ml per kg body weight per hour. We should keep our target urine output 0.5 ml per kg per hour. Okay. Now, after ABC, right, I have secured airway, I have taken care of the breathing, I have taken care of the circulation. Now I would do a very fast, right, neurological examination, right? You know, number of times, even before giving the sedative for intubating the patient, number of times I need to intubate the patient, we do a quick neurological assessment, right? Because we want to, let's say, distinguish a true coma from a patient who is malingering. So number of time hand drop from head. We take the hand of the patient and drop it from the head. If patient try to control his hand, then most probably patient still have the control, his or she is malingering, right? So we do a hand drop method. Then we see pupillary size. Number of drugs will give for intubation or other thing can affect the pupillary size. So we assess the pupillary size, we assess the response to light, right? We see any abnormal eye movement, we see the grimacing and withdrawal from noxious stimuli, we see the plantar response of the patient. Because this all will help us in briefing, concising our DD, differential diagnosis. This all will try to point us towards the etiology which has brought the patient in altered consciousness. Okay, so we do a brief mandatory neurological examination. Okay, now we start the management of the coma patient. Right, now initial management. A quick blood sugar is done, and if required, dextrose is given for hypoglycemia. Now hypoglycemia is one of the most important reversible cause of coma. Then number of patient, we will know the etiology at once there, because let's say a young boy has been brought and it is said that he is an opioid abuser and he has taken opioid. So maybe naloxone will give naloxone and reverse the opioid, right? Now, so I will talk about something called coma cocktail. Whenever we get a patient in coma, initial management after stabilizing airway, breathing and circulation is to give coma cocktail, in which glucose, thiamine and naloxone is given to the patient, right? Supportive care and sedation for altered, agitated or withdrawal state. Number of time patient in coma are not, let's say, totally in subtle state. They may be in agitated, they are altered sense of consciousness, right? They are in agitated state. So we need, in these patients, we need to give them sedative etc. for support, as a supportive care. Then we give fluids, as I talked about, for dehydration, hypovolemia, hypotension, hyperosmolar states, right? If I get a quick information about the investigation and I see that most probably the coma is due to hypernatremia or hyponatremia, hypovolemia, accordingly we start our management, right? And if I suspect my patient has some brain infection, let's say when I did the physical examination systematically of this patient, then it pointed that patient has altered consciousness and some focal neurological deficits and maybe a rigid neck, which gave me an idea that most probably that patient has some brain infection, right? Then we can even start antibiotic as fast as possible in these patients in case of suspected meningitis. So these are the initial management which is started in the emergency department before a final etiology and a more let's say preferred management is, or more better management is started by the neuro physician. Before that, in emergency department, initial management is started to buy the time, to minimize the interruption of the time in starting proper management. So we start giving the supportive care and doing the initial management, right? So I talked about coma cocktail. We give glucose, thiamine and naloxone number of time in these patients, right? Then once we have given these drugs and fluids, we have to see that whether the patient is warm or not. Number of times the patient, coma patient, neglected, hypothermic, and hypothermia is also causing the coma, has deteriorated the state of the patient along with other conditions. So we start rewarming, or if the patient is hyperthermic, heat stroke, then if any cause I'm able to see, I start working on that cause in emergency department. So I start rewarming, I start aggressive cooling for the temperature extremes, right? Any evident cause, any known drug I get to know, like patient has taken benzodiazepine or digoxin toxicity, right? Anything, I will start giving antidote for that specific toxin, right? So we'll start giving antidote for that particular toxin, right? And if required, we can go for a controlled reduction in blood pressure, right? For hypertensive encephalopathy. Because of extreme increase in blood pressure, I told you, we have to keep the target blood pressure at 100 to above 100 mm of Hg. Above 160 mm of Hg, if mean arterial pressure is increasing, then we have to reduce it. But we have to keep it above 100 mm of Hg. But in hypertensive encephalopathy, patient can also go into hypertensive encephalopathy. Hypotension can cause coma, hypertension can cause coma. So we start having a controlled reduction of the blood pressure in these patients also. Okay. Then if hyponatremia, I had a patient, TURP patient, let's say post-op room in PACU, post-op anesthesia care unit, and patient has altered consciousness. Very quickly I will come to know the reason, that most probably it is hyponatremia, right? Hyponatremia producing this coma. So I'll start giving my patient 3% or 6% hypotonic normal saline. So if I see an evident cause, we start treating that, right? And number of times in CNS lesions, we know that metastasis CNS lesion most probably has caused coma. We can even start glucocorticoids, right? And as I told you, any patient in coma, we give coma cocktail, that is thiamine, glucose and opioid. We can consider thiamine, further dose of thiamine, if vernix encephalopathy is suspected. I have a patient with poor nutritional status, right? I can suspect vernix encephalopathy in these patients. So once I have done a stabilization of these patients, of coma patient, taken care of ABC, delineated the etiology, tried to go for the most probable cause of this altered consciousness, now I will have to dispose my patient. Now decision to admit the patient to ICU or hospital ward may be based on hemodynamic stability, etiology of the acute mental status, expected course, and need for close monitoring and airway management issue, right? And our resources of institution. So in emergency department, it is for us to decide where we have to dispose the patient, whether we have to send the patient to ICU for the further management, which would be guided by the hemodynamic status, which would be guided for need for ventilation of the patient, which would be guided by the further course of deterioration in the patient, right? Or patient needs to be sent to the ward. So patient is ultimately disposed either to ICU or neurology ward for further management. In emergency department, only the stabilization and initial assessment is done so that the delay in starting the treatment is prevented and damage due to coma is prevented. Okay.